Analysis of medications.
Onfi is a third-generation, long-acting benzodiazepine used in the management of seizure disorders. Onfi binds to benzodiazepine receptors and increases GABA-X. GABA is the primary inhibitory neurotransmitter of the central nervous system. Onfi decreases neuronal excitability in the CNS and lowers the seizure threshold, decreasing the chance the patient will have a seizure. Pharmacodynamics. The half-life of Onfi is 36 to 42 hours of the parent drug and 71 to 72 hours of its active metabolite. The time to peak drug concentration is 30 minutes to 4 hours. Pharmacokinetics. Onfi has an 87% bioavailability. It is lipophilic and 80 to 90% protein bound. It is metabolized through demethylation. It is a substrate of 2B6, 2C19, and 3A4. It is a weak inducer of 3A4 and a weak inhibitor of 2D6. Onfi is excreted in the urine and the feces. For patients that are known poor 2C19 metabolizers, the dose should be adjusted. Onfi should not be used with sodium oxybate due to the increased risk of CNS and respiratory depression. Caution is advised when given with methadone. Caution is also advised when Onfi is given with clonazepam, lorazepam, and phenobarbital due to increased risk of CNS depression. Below are the common side effects of Onfi. KL suffers from drooling, constipation, and has a previous history of pneumonia. Onfi is pregnancy category C and possibly unsafe for use in lactation. It should be used in caution with patients who have current or past alcohol or drug abuse, elderly and debilitated patients, and patients with hepatic or pulmonary impairment. Caution advised when Onfi is used in patients with depression, and its effectiveness has not been determined in patients less than 2 years old.
Phenobarbital is a CNS depressant by binding to barbiturate sites at GABA receptor complexes, enhancing GABA activity. Increased GABA activity decreases neuronal excitability and reduces seizure threshold. It is used in the management for generalized grand mal and partial seizures, which KL has. Pharmacodynamics for phenobarbital include the onset of action is 20 to 60 minutes, its duration of action is 6 to 10 hours, and its half-life is 2 to 6 days. Pharmacokinetics of phenobarbital include a 70 to 90% bioavailability. It is 20 to 45% protein bound, and metabolism, it is hydroxylated by the liver to form an inactive metabolite.
Phenobarbital is a substrate and inhibitor of many CYP450 isoenzymes. It is eliminated in the urine.
Phenobarbital interacts with methadone and is contraindicated in patients with severe uncontrolled pain and patients with severe respiratory distress.
Caution advised when phenobarbital is given with baclofen, clonazepam, lorazepam, and clobazam due to increased risk of CNS depression and psychomotor impairment.
Here are the common side effects with phenobarbital. Some of the common ones include drowsiness, nausea and vomiting, rash, pain, and swelling.
Phenobarbital should not be used in pregnancy, and its safety is unknown in lactation. It is contraindicated in patients with a history of porphyria, severe hepatic impairment, and respiratory dysfunction.
Phenobarbital should be reduced in patients with hepatic and renal impairment, elderly patients, and caution should be advised in patients who have depression and a history of uremia.
Klonopin is a benzodiazepine anticonvulsant used in the treatment of petit mal seizures, akinetic, and myoclonic seizures. Klonopin binds to benzodiazepine sites on GABA and increases the inhibitory effects of GABA to decrease the seizure threshold. Pharmacokinetics. Klonopin's onset of action is 20 to 60 minutes, and it has a half-life of 22 to 23 hours. Pharmacokinetics. Klonopin has a 90% bioavailability and is 85% protein bound. It is metabolized in the liver by CYP3A4, and the metabolites are excreted as glucuronide or sulfate conjugates. Less than 2% is excreted in the urine. Caution is advised when giving Klonopin with methadone, baclofen, or lorazepam due to an increased risk of CNS depression and psychomotor impairment, vasodilation, and hypotension. Caution is also advised when giving Klonopin with phenobarbital and clobazam due to the increased risk of CNS depression and other adverse additive effects. There are many common side effects of Klonopin. KL suffers from constipation, which is one of these common side effects. Klonopin should not be used in pregnancy, and it is not safe for use in lactation. It is contraindicated in patients with severe liver disease and patients who have narrow-angle glaucoma. Caution advised when giving Klonopin to patients with chronic respiratory disease, hepatic disease, impaired renal function, or patients who are elderly or debilitated. You should avoid abrupt withdrawal of Klonopin due to risk of increased seizure activity or status epilepticus. Keppra is used as adjunct therapy in the treatment of seizures. Its mechanism of action is unknown, but there are many theories. Its mechanism of action may be related to inhibition of the voltage-dependent N-type calcium channels, blockade of GABAergic inhibitory transmission through displacement of negative modulators, reversal of the inhibition of glycine currents, reduction of delayed rectifier potassium current, and binding to synaptic proteins that modulate neurotransmitter release.
Pharmacodynamics of Keppra include a half-life of 6 to 8 hours.
Keppra does not have any known interactions with KL's current medications. However, it should not be given with ginkgo biloba due to the possibility of decreased anticonvulsant activity. Keppra should also not be given with Renagel due to the decrease in anticonvulsant activity. Common side effects of Keppra include somnolence, nausea and vomiting, anorexia, fatigue, diarrhea, pain, agitation, depression, anxiety, and confusion.
Keppra's use in special populations include a pregnancy category of C. It's possibly safe in lactation, and doses do need to be adjusted in patients with known renal or hepatic impairment. There is a 40% higher clearance in the pediatric patients ages 6 to 12.
Ativan is a benzodiazepine used to treat seizure disorders by binding to benzodiazepine receptors and enhancing GABA effects to decrease neuronal hyperactivity and lower the seizure threshold, decreasing the chance that KL will have seizures.
The pharmacodynamics of Ativan include an onset of action in 60 minutes, a duration of 8 to 12 hours, and a half-life of 6 to 17 hours.
Pharmacokinetics. Ativan is rapidly and completely absorbed following oral administration with 90 to 93% bioavailability. It is 85% protein bound. It is metabolized by glucuronide conjugation in the liver to form inactive metabolites and is eliminated through the urine. Caution is advised when giving Ativan with methadone due to an increased risk of vasodilation, hypotension, CNS and respiratory depression, and psychomotor impairment. Caution is also advised when giving Ativan with clonazepam due to an increased risk of CNS depression and other adverse effects. Caution is also advised when giving Ativan with phenobarbital and clobazam due to an increased risk of CNS depression and psychomotor impairment.
Common side effects of Ativan include sedation, dizziness, dystonia, and irritability.
Ativan is a pregnancy category D medication and should not be used in pregnancy. It is probably safe for use in lactation, and caution should be advised in patients with pulmonary, renal, or hepatic impairment, those with a history of alcohol or drug abuse, patient with a history of seizures such as KL, and elderly or debilitated patients. Morphine is an opioid agonist that binds to various opioid receptors to produce analgesic and sedative effects to treat pain. Opioid receptors include G protein-coupled receptors located in the brain and spinal cord. These areas are involved in the transmission and modulation of pain. Peripheral sensory nerve endings are somewhat affected by these opioid receptors as well.
Pharmacodynamics are specific to route of administration. Half-life is 2 to 4 hours, oral solution has a peak of 1 hour, and the duration is 3 to 5 hours. Morphine has variable absorption, and the distribution is in the skeletal muscle, liver, kidneys, lung, intestinal tracts, spleen, brain, breast milk, and placenta. Morphine is metabolized in the liver and the GI tract. It has minimal CYP450 metabolism, and it is a P-glycoprotein substrate. It is eliminated in the urine and the feces.
Morphine interacts with food and baclofen. Taking morphine with food may decrease bioavailability. Baclofen may increase the risk of CNS depression and psychomotor impairment.
Caution is advised when morphine is given with clonazepam and lorazepam because it increases vasodilation, there is a risk for hypotension, CNS and respiratory depression, and psychomotor impairments.